shields. It must be exciting again.
So the title of my talk is Not One, but Two. The story goes, this is a 67-year-old woman who had blurred vision for 1 month, and she had floaters and flashes in her left eye. So something was wrong with her left eye. Her vision was 20/50 and 20/30. She had a previous ovarian cyst and a breast biopsy. And her past family history is that her parents and brother both had lung cancer, and her sister had liver cancer. Generally, when I take a history on a patient with a lesion in the eye, I'm looking for related conditions. So just keep her past history in your mind as we go through her case. So on fundoscopy, the right eye was healthy, the left eye showed this. What is this? It's a pigmented choroidal mass. Could be a large nevus, but very suspicious for a small melanoma. There's overlying orange pigment and subretinal fluid. By autofluorescence, it was bright, suggestive of orange pigment, and there was a puddle of subretinal fluid on autofluorescence right here where I'm outlining it. OCT showed shallow subretinal fluid and what we call shaggy photoreceptors. This is a sign that there's fresh retinal detachment. Ultrasound showed an echolucent mass of 3.2 millimeters, and there was no doubt in our mind that she had a small choroidal melanoma. This was an active melanoma. We measured it at 10 by 7 millimeters base and 3.2 millimeters in thickness. Okay, so we have a patient with a choroidal melanoma, a little bit of family history of cancer. Let's look around the rest of her eye. We checked the entire fundus, and we noticed this superiorly in the same eye. There was overlying orange pigment. It was a choroidal mass. Subretinal fluid was seen on OCT. It measured 2.4 millimeters in thickness and was lucent. It was very consistent with a melanoma. So this is melanoma number 2 in this patient's left eye, measuring 8 by 6 millimeters base and 2.4 millimeters in thickness. So now we have a patient who has 2 melanomas in one eye. There was no ocular melanocytosis connecting the two. They are 2 separate melanomas in one eye. So we have to make the decision, do we enucleate if these are awfully small? Can we treat them with plaque radiation, proton beam radiation, or somehow a combination of plaque and TTT? So what we did was we measured the entire extent of both of them and fashioned a custom designed plaque to cover both of them and treat them both at once. So I just want to say a few words on multifocal pigmented choroidal tumors. You can get this in several different situations, from choroidal metastasis from skin melanoma, but she didn't have skin melanoma. You can see them in multifocal primary choroidal melanoma. Usually those patients have ocular melanocytosis, but she didn't have melanocytosis. You can see this with choroidal bilateral diffuse melanocytic proliferation, but this wasn't typical for that. Her other eye was fine. Could these be choroidal nevi that are multifocal? Not likely. How about choroidal freckling and neurofibromatosis type 1? The most common finding with NF1? Nah, they usually don't have orange pigment. And these aren't choroidal hemorrhages. So we were a little bit concerned what this was going on in her left eye and worried that there could be something else going on because she had 2 melanomas in one eye. Let's look back over the literature. A few years ago, we wrote about 2 melanomas in a child with melanocytosis, but she didn't have ocular melanocytosis. And Noemi Lois, when she was with us, wrote a paper about a patient who had 3 melanomas. And that patient did not have ocular melanocytosis, but we couldn't figure why he had 3 melanomas. But now we speculate why he did, and I'll tell you in a minute. So back to our patient. She had 2 melanomas. We checked her skin, her body MRI, lung CT, family history. Skin was negative. Body MRI showed she had renal cell carcinoma. But that doesn't produce melanocytic tumors in the eye. She didn't have lung cancer, and I already mentioned her family history of multiple cancers. We suspected she had BAP1 cancer predisposition syndrome. This is a syndrome that predisposes you to multiple melanomas in the eye, systemic cancers in the patient, and a strong family history of cancer, all of which she had. She had germline BAP1 mutation. Let's talk a little bit about BAP1 mutation. This is an article from 2012, just 4 years ago. This cancer predisposition is a new syndrome that is now known to cause multifocal melanoma and familial melanoma, as well as systemic cancers in patients with uveal melanoma. It's a new class of renal cell carcinoma at risk for other cancers. And if you look at this paper, the BAP1 protein is a D-ubiquitinase and is inactivated in 15% of clear cell renal cell carcinomas. So BAP1 loss can lead to renal cell carcinoma, and it's also associated with high-grade uveal melanoma. So BAP1 in renal cell carcinoma is associated with poor prognosis, just like it is associated with poor prognosis with uveal melanoma. So BAP1 is a tumor suppressor in renal cell carcinoma, and now in this report they showed that 70% of clear cell renal cell carcinomas lose BAP1, they have a BAP1 mutation. So if you have germline BAP1 mutation, you're at risk for this list that I have here: multiple family cancers, mesothelioma, lung cancer, pancreatic cancer, renal cell carcinoma, skin melanoma, and melanocytic tumors, and the last on the list, uveal melanoma. So no longer can we tell our patients uveal melanoma has no syndromes. It now has a syndrome, and that's BAP1 cancer predisposition syndrome. Now, if you do a needle biopsy of the tumor and you find BAP1 in the tumor, but not in the blood, that's somatic mutation. That means the patient's at risk for metastasis. To be found with germline mutation, you have to find it in the blood. That means at risk for other cancers. So a nice report came out of Harvard, Gupta and Ivana Kim. They looked at 507 patients with uveal melanoma, a very large cohort, and found overall BAP1 mutation in the blood was present in 5% of these patients. There were 18 polymorphisms, 9 were novel. But the most important thing that they found in this really, I think, breakthrough report, patients with germline BAP1 mutation versus normal patients, they found those with BAP1 had significantly larger diameter, ciliary body location, metastatic disease, and 100% of them had family history of cancer. Often it was skin melanoma, and often it was ocular melanoma. So these are things that make you worry about BAP1 mutation. Then from Finland, Kavela and his team also looked at BAP1 mutation in Finnish patients with uveal melanoma. At 148 patients with uveal melanoma, they found about the same result. 2% of patients had germline mutation in BAP1, and if they were less than age 50, it increased to 4% had BAP1 mutation, and they found no greater incidence of BAP1 in Finnish people with uveal melanoma compared to other people. Then there was this really nice, large population study on BAP1 mutation. These are patients who had multiple cancers that dated back to the 1700s. This was published in 2015. It was a very large lineage. This is the lineage of this giant family that originated from Germany and migrated into the United States and they had a very high rate of malignancies. And they studied this family. They originated in Germany and migrated to the United States, and they found multiple patients with uveal melanoma, circled in red, and multiple patients with mesothelioma of the lung, circled in blue. And they found that they carried BAP1 mutation too. So this is the first observation, we published this case, of multifocal uveal melanoma in a patient with BAP1 germline mutation. We advise that anyone who has uveal melanoma with family history of cancer, bilateral melanoma, or multifocal uveal melanoma have BAP1 testing. We offer it to all of our patients who have these findings, but I think in the future, all patients with uveal melanoma will be getting germline BAP1 mutation. This is the article that we published in Retinal Cases and Brief Reports. Thank you. Any questions or comments? It's interesting that this, syndrome was only described 4 or 5 years ago. So I think we're learning more and more about, predisposition syndromes now for cancer. And this is one that leads to melanoma. Thank you.
So next would be Professor Hiroshi Goto from